For those so inclined, please bow your heads in prayer. Lord, as we go about the business of the Union County Consolidated Human Services Board, we ask that you impart wisdom. We ask that you guide us as we make decisions and deliberate and discuss and hopefully learn. And Lord, as you guide us in making decisions for the county, please keep us focused on the best interests of the county. Keep that front of mind, and just let all of our deliberations be in a spirit of amity and friendship. Amen.
Thank you, Commissioner. And can we have I was not here last month, but can we have, has everybody had a chance to review the minutes for last month? If so, can we get a motion? Okay, Amy?
Second.
Okay, Meg, motions and seconds it. So the motion is approved. Can we get, has everybody had a chance to see today's or tonight's agenda? Okay, we got a motion for approved by Amy, second by Meg. Okay. So, I know this is not on the agenda, but I want to take liberty to, this I just understand is Meg's last board meeting, and Meg has been on the board for 8 years. She won't be here next month, so I was hoping everybody could just give a thanks for her service for 8 years. Okay. So now I guess it's time, is there any old business that we have here? Well, if there's no old business, is it time for the executive director's report?
I think the hopefully good news, because we do have a couple of other reports that are a little longer tonight, but is I don't have anything to update. I know I need to provide an update on the public health director position, and we are getting closer to being able to have an announcement in that space, but aren't ready to do that yet. So I apologize for not having that information for you, because I know everybody's excited to know. And so hopefully by next month that will be able to happen. And the only other thing I do want to make sure that I say, I know several of you are going to participate tomorrow in some accreditation related activities. Wednesday. And appreciate that very much. I think Dennis probably will talk about that a little bit more maybe at the end, but just want to say thank you to you all for your time and participation in that process.
Well, thank you, Janet. So I guess we can jump right into the division reports.
Well, I'll start since I'm on the end over here. Two things I'll mention. One is the accreditation that Janet mentioned. Our site visit will be this Wednesday. It's an all-day event that we're thoroughly looking forward to. Yes, somebody smiled over there. I'm glad you got it. There's a lot of work going into providing evidence, even at the last minutes before this meeting, of putting various pieces of evidence together for the 147 different activities that we've got to provide evidence for to be accredited. So I want to thank the staff for the work that's gone into this. And then we'll know a few weeks afterwards, we'll find out, and then be able to report that certainly in November. But I want to also thank Earl and Amy and Brandy, who are going to be representing the board. As Janet mentioned, there'll be a 30-minute virtual call with the site team They've done it a little differently. All of the site members are not here. It's sort of split up. There's going to be about 3 that'll be here, and then there will be some others that are virtual. But anyway, appreciate the support in handling those different aspects. The other thing I want to mention is also thank the staff, thank the board members who participated. I've been a health director for pushing 20 years, and I have never had 2 potentially dangerous dog declarations within a month's time. But since your last meeting, we have actually had 2 potentially dangerous dog declaration appeals. And as you know, the board is the appealing body for that. And in some facet, either the first one or the second one that we had, I want to thank Meg and Earl and Amy and Brandy for the participation in those 3-member panels for those particular hearings. That's all that I have.
Dennis, can I, so Wednesday, at 12:30, can Carla send that link out again for that virtual meeting?
Yeah, we'll make sure it gets back out.
Okay, thank you.
I think next we have the communicable disease report.
Oh, I'm sorry. Yeah, I jumped ahead, didn't I?
That's okay. So Megan?
Thank you. I'm Megan Troll, Community Disease Supervisor with Union County PD. And this is our annual report. And this is showing the 2023 statistics. This is an overview of what we're going to do. So this is enteric, food, and waterborne. I've highlighted those that...
Can you speak up a little bit?
Yeah. I've highlighted the red, the events for 2023 that exceeded the 5-year average. And that's kind of like an average that is commonly used with communicable diseases. I've also added the incidence rate. That'll be the first year that we've done that. And that was pulled from the North Carolina CD dashboard. So as you can see, a lot of the event occurrence has kind of gone up across the board. No identified outbreaks or epidemiological driving factors. With food, enteric, food, and waterborne, the primary driving factors are travel is a lot of it, some due to contaminated food or water sources, and some person to person. A lot of the response is based on control measures and education. We tailor education to each case, and it just depends on risk factors. We always include education like hygiene, proper food handling, and food safety. Whenever we do have epidemiologic links, we make that referral sometimes to environmental health, and they do that investigation accordingly. Vaccine preventable, this will be the first year that COVID was excluded altogether. COVID and COVID deaths are no longer reportable. We do continue to track outbreaks. And again, no real driving factors. A lot of the varicella cases that we've seen were among unvaccinated children. The respiratory illness surveillance, we pull this data from the North Carolina dashboard. They do annual surveillance. We also participate in the influenza-like illness reporting, so we collect data on all of the cases that we test and those that are positive, and report that to the CDC. Again, this is just some information about influenza-like illness, the variants that were tested and which were positive, and then some information about the different respiratory viruses and their rates. Direct contact and respiratory illnesses. You will see TB a little more detail about the TB on the next slide. For the invasive group A strep, we did have an outbreak this year, in 2023, in a long-term care facility. I am remiss I can't remember exactly how many cases resulted of that, but I can get you that information. And so, in 2023, we did have 6 active cases for TB, which resulted in 40 contact investigations. We had 160 LTBI cases evaluated. LTBI treatment is optional for patients, but we do investigate, we collect testing information, we do chest x-rays, and then offer treatment. 10 completed treatment in 2023.
Can you share what latent TB is?
What's LTBI?
Latent TB infection. I'm sorry, what was the question?
What is latent TB?
Okay.
So when you say treatment completed, how many were started?
I'm not sure, I can get you that information. We do have a log.
Tuberculosis was created by starting but not completing.
Right. Well, typically, if they are not completed in 2023, it's because they're continuing treatment. Sometimes that can be 3 to 4 months. So.
TB treatment's at least 3 months usually.
Right.
And sometimes 6 and whatnot.
Right.
So if you start the treatment and don't complete the treatment,
Right.
that's how you create resistance.
Right. And then we document those loss to follow up, and we report that to the state.
But at this time, we don't know how many of the 160 declined of the late.
Right. So some of them could have declined treatment, some of them could have started treatment and did not complete treatment.
And those would be the ones I'd be concerned about. Okay.
I think Janet wanted to know what is latent TB. Janet wanted to know what is latent TB.
Okay, so latent TB infection is a person who was infected with TB, but that infection is dormant in their body. It's not causing active disease. They do not have they don't have any symptoms, and they are not contagious, which is why it is optional.
What type of treatments, I heard something before called INH, I know that's an acronym, but what type of treatments do you use for, someone might have?
So there's different treatment regimens. The most common is called RIPE. It is INH, ethambutol, rifampin, and PZA. If for some reason the patient does not respond well to that treatment, whether their lab values change, they have some, liver issues as a response. Some people have symptoms that they cannot tolerate, so we can change that medication really based on a number of different things. The deviation in the preferred treatment can lengthen that treatment. It can change. So there is typically 2 phases of treatment. The first is an intensive phase where they take medication daily for at least 8 weeks. And then they go to a continuation phase where they take medication Monday, Wednesday, Friday. So any deviation of that treatment sometimes they will have to take medication daily throughout their treatment. For the most part, some people can end treatment 6 months. Some people need an extended time to 9 months. We've even seen up to 12 months, or even more, but typically if those are really special cases. But
See, is it true that once a person has been exposed, and even if they have taken treatment, that they will always have a positive positive tests when they take?
So even, yeah, even those that have taken LTBI treatment, you know, if you have a positive quantiferon or PPD, you're always gonna have that. Which is why for most people who have positives, we do recommend, annual screening for symptoms. And then we can provide that documentation just to say, yes, we've checked in with you. You know, you're not having any symptoms of active infection. And if anytime anybody, if they decline treatment now, they choose later on, okay, now I'm ready. Because we don't recommend starting a regimen that you're not gonna be able to complete. To his point, that would be a concern for resistance. So if at any point down the line they decided, yes, I wanted to do treatment now, we would obviously initiate that.
Thank you.
Thank you. And I will get that, how many initiated treatment for 2023. Any other questions? He's really fascinating, so. All right, for vector-borne and zoonotics, you know, I think the biggest thing that kind of screams is rabies in animals. We haven't had nearly that many this year, so that's good. And then, of course, animal control and Dr. Broadway's team's always great about doing the rabies vaccinations for the animals. One thing that was some of a concern, even earlier this year, is dengue is one that we've had to send out some health alerts about having local acquired dengue, so those that are not associated with travel. In this case, the malaria case was a travel-related case. Yeah. All right. And then meningitis. And CRE. A big portion of those CRE case, well, I say a big portion, a lot of them were in the long-term care facilities. With each one of those, we do surveillance with those long-term care facilities and education with each case. With the CD outbreaks, I know one was a GI outbreak in a school. We suspected norovirus, but we did not have any confirmatory testing with that outbreak. They just had a cluster of GI illnesses. And the other was the strep, yeah, invasive strep. I was going to say staph. And then just for reference, an outbreak is 2 or more cases over a 28-day period in congregate living settings, and then the cluster is 5 or more cases over a 14-day period with an epi-link in other settings. For immunization reviews, I did fail to include the total vaccines administered, so I will get you that information. We pull that information from the North Carolina registry. The biggest thing is our benchmark. So annually, the state pulls the North Carolina benchmark. That includes our in-house clients and then county residents. And it does tell the number of clients assessed and then what percent met benchmark. They do assess for 24-month-olds, so 2-year-old, and they assess like who is up to date at that time, so who's up to date for their childhood vaccinations. And that is always pulled October 1st for the year prior.
Do you know what, on that trend with the 3% decline in the county, was that trending down previously in the year prior to that, 21, 22?
It was, yes. Yeah. And so not only did we decrease, I base that on what our goal is, which is kind of always what we want to aspire to, but we did have a decrease from the year prior. And that is not just something that we've seen. I'll talk a little bit about it later on in the presentation. That is seen statewide. It's just not for Union County,
But
not specific to Union
multi-years,
County.
like more than 2 years, like,
So they just ran our numbers for 24, and this will be the second or third year that we have seen the decline. I know there's lots of information on this, on this slide. Sexually transmitted and bloodborne diseases. You know, primary and secondary syphilis, and then early latent syphilis. Last year, that was an alert for us. That was showing really steep inclines. There were impacts for congenital syphilis. We did attend a symposium this year, and it was reported that that is starting to come back down. So that's, you know, numbers are starting to trend favorable for that. Mpox, we did so in 2022. We did have the 6 cases. That's when the outbreak emerged. We did not have any cases for 2023. We focused a lot on vaccination and education. We did have 1 case in 2024, and we still have vaccine available. We still continue to push that out. Any questions?
Mr. Red?
Yeah.
So is the red saying that we're just way over? Is that what that is signifying?
Not necessarily. It's just an easy way to see, you know, what trends are, you know, trending unfavorably versus favorably. Just kind of data visualization to say, okay, for our 5-year average, just say for chlamydia, our 5-year average was 977 cases, and then we had 1,000 cases identified for Union County residents in 2023.
I was just trying to get some, like, maybe compared to the state, are we lower, are we higher, or how do we stand in comparison with other localities or what the state average is?
I can get that information for you. Also, there is the data dashboard that has lots of great, not that I can't get that for you, but if you are ever just interested in like how we compare to other counties or other states, North Carolina did roll out the data dashboard this year. It is updated quarterly, and you can select different counties to see exactly, you know, kind of how we're on trend and how the state. You know, anecdotally, I would say it's pretty similar to the trends they've seen statewide.
do you know if the meningitis were vaccinated?
I do not. I mean, we have that information. We record that information with cases, but I'd have to get that information for you.
Chlamydia number seems pretty consistent. I mean, it's upper 900s
Yeah.
to 1,000.
Right.
Is that a segment of our population? Is there education? How are we?
Well, a major portion of it's going to be young adults. That is a trend that is since the age of time, really. We do try to, so especially in 2023, we did attempt to do lots of education. We did some outreach events where we went and talked about screening. We offered some other STI screening out in the community. So there's still lots of work to be done, yes. And, you know, a lot of it is risk reduction, you know, trying to get that education. Another thing that we have started this year, is doxy-pep, so those that are at high risk, and you have to meet criteria. But if you have condomless sex, they can take doxy-pep, and it's actually to prevent infections, not to just treat. So as as data comes out for those studies also, because studies vary on, well, just, you know, it is targeted for men who have sex with men. And the benefits of that we're still learning more about for women and other people of risk groups.
For your question about the chlamydia incident rate compared to North Carolina, North Carolina's incident rate for chlamydia is 608. So we're under that considerably. I mean, not that that's, I don't want to paint a great picture, but to your question.
All right, and just to kind of review some of the threats, like I mentioned, we were seeing staggering increased rates of syphilis. We did do targeted outreach for screening, so we went out to the community, offered rapid screening for HIV and syphilis. We sent education to providers, OD providers, local providers, to encourage prompt testing and treatment, especially for those vulnerable OB patients, to prevent congenital syphilis, and then just talk about prompt treatment. We did have a surge of need for refugee health screenings. We did dedicate a CD nurse to screening and follow-up, so we incorporate refugee health screenings into our TB clinic, and we were just seeing an overwhelming number of refugee health screenings, patient presenting for refugee health. And so to kind of offset some of that, one of our CD nurses was dedicated to looking at those labs, following up, and sending that information out, because they will need it for their physical exams for their providers. And then just the increase in TB workload. We also, the same CD nurse was dedicated to TB clinic and that follow-up.
There's a specific clinic just for TB?
Yes.
And when you say refugees, what exactly defines a refugee?
So refugees, anybody, and refugees are people who immigrate to the country.
Okay.
They have persecution in their country, so they are cleared to immigrate.
So immigrants?
Yes.
Okay.
They are immigrants. And it could be parolees, they could have family here, so You for You, United for Ukraine, was another, I would say.
How many of these immigrants are coming from high-risk areas? Like, let's say, I'm just using an example, because I spent a lot of time in the Philippines, lots of TB in the Philippines.
Right.
Do we follow demographics like that? Do we look, it's not a label, it's an actual reality.
Right.
Bringing disease here, so do we track that?
Yeah, so every person that comes through our refugee health screening, we offer TB screening as a part of that. And we document what country.
Do you mean
they're
like
coming from.
x-rays, or do you mean the skin? Because a lot of these countries have vaccine, they have TB vaccine, and you can't do the skin test on them.
Right, so anybody that we have who have had the BCG vaccine,
Yeah.
we do quantiferon.
Most are Ukrainians, if I'm not mistaken.
A bulk of them were from Ukraine, yeah.
And it's only those who are actually coming to your clinic to seek out a regular doctor, or they're sick at the time?
So they would be coming, typically, so if they're coming in for refugee health screening, they're specifically coming for, they are seeking out the health screening, which we offer TB screening, we offer other CD like HIV, hepatitis, we do like GI culture.
Is this something when they come into the county, they're given information about? Or do you guys
Yes.
go out in the community where they are located and do outreach?
So they are referred, there's a couple of different ways. So we get notification that a refugee is moving to our county. We have 30 days to contact them. Many of them are already referred to us. There are several resettlement agencies that they kind of case manage that, and they make those appointments for them.
Now, look, I'm asking this because I'm trying to see if there's a distinction. When you say refugee, obviously it's immigrants over here. This is people that you are told about that are coming in the area. Does this mean anybody coming over the border that just might, so it's just a refugee status that you're told about? It does not include the people that might have just
Correct.
come in here that are not aware of? Okay.
That's correct.
Most are parolees, so that meaning that they have, they're legally coming here and vetted through
Okay.
the federal government.
Okay.
But it's not a requirement to be screened, it's a service that you offer.
No, they are required to be.
There is a requirement, okay.
That is like their agreement, like they are coming in as a refugee, they agree to this screening. And many of them are screened both before they travel and then once they arrive. They also do, so we have what's called Class B. So if they are screened before travel and they have a positive test, they are not active. We also get that alert, and we have 30 days to follow up with those cases if they are deemed to have LTBI.
Who alerts you and notifies you? Is it the government or you said agencies?
The government, yes. So it's, well, both, yeah. Well, so CDC, it's called EDN, is the database that sends us the notifications. All right, and I'd like to just kind of throw like what our antennas are up about. Obviously, a common theme and kind of a lot of our discussion has been globalization. Also, with globalization comes emerging conditions. Obviously, there are many areas in the world that are not quite as fortunate as us to have surveillance systems. So, they do have widespread infections that can pose a serious threat to public health. And with that, issues that are across the world can be an issue for our community within a matter of days. So that is one of the biggest concerns. We've seen more and more about measles, antibiotic resistance is increasing worldwide, accelerated global travel, and we have seen that reflected in a lot of our case investigations. Just kind of goes hand in hand with our immunization benchmarks, and it has continued this year. Vaccine hesitancy along with vaccine exemption rates for Union County kindergarten has increased from 2.5% in 2020 to 6.5% in 2023. And then we've already talked a lot about
what that
refugee
rate
health.
is in '24 so far?
Not yet, no. I would venture to say it's going to be higher.
You said that on the last one, that the clinics are saturated with those immigrating to Union County. Like, what kind of volume are we talking about?
I will have to pull those numbers for you, but there, we had to, temporarily, we had to increase our TB clinic, because we typically run that Monday and Thursdays. We had to add a day on Tuesday to kind of absorb a lot of, like, to make sure that people are getting their LTBI meds, because those appointments were being taken with their refugee health screenings. We do have a plan for that. We are going to pull refugee health out of the TV to make sure we have adequate appointments for both populations. But, I mean, it's a lot.
One of the questions that I had with this, because of this refugee increase that you're talking about, is this the community or demographic where you're seeing these outbreaks?
This year, I will say, we did have pertussis outbreaks.
In these communities and demographics?
In the community, yes. So vaccine preventable diseases is a concern for some of the populations. They do have cultural issues with vaccines, and that's something we educate whenever we can. We do provide vaccine. We offer it with each appointment, so.
The immunization exemption rate, we're seeing that across the state. You said similar, numbers?
Yes, ma'am.
We're probably a little higher than the state average.
We are, yes. It is a concern across the state, but we are higher than the state average. I just kind of wanted, because it's easy to say we have an issue with vaccine hesitancy, but this is, like, every day we see things in social media. How can I go about vaccine hesitancy? And so it's a growing concern, and I wanted to, make sure that it's recognized that it's a growing concern for Union County. And then again, with just, we've already talked about a lot of it, but so we do vaccine lookups, really any community event that we are invited to. We go out, make sure those that are so inclined, we look up their vaccines, make sure they are up to date. We do offer a vaccine exclusion clinic. We have that annually, so typically on or after exclusion date, we host a clinic. It's walk-in, it's well attended, that they can come in and get vaccines so they can get back to school quickly. We do continue to collaborate with Union County Public School to identify any public health concerns. We have a very good relationship with them. Anytime they have any concerns or questions about vaccines or really anything, we are happy to help and have a good support there. We do speaking engagements to offer education to like medical assistants that are working in these local provider offices. And then anytime we have any opportunity to speak about vaccines, we do. Any questions?
I have a few.
Yes.
Because this touches right at home. I was having a discussion with Mr. Joyner before this. I'm fortunate enough to work directly and indirectly with all demographics of parents from vaccinating on schedule, delayed, and not. I work indirectly with a pediatrician here locally of 30 plus years who has been trying to bring some of this to attention as far as 2 years ago, because we saw what was coming down. With vaccine hesitancy, I feel like we've got to be willing to have open conversations about vaccine hesitancy, because so many things have come to the forefront over the last few years. We can't be having conversations anti versus pro issue. The biggest question is, how do we bring trust back into the medical conversation as well as medical ethical issues? We have two main healthcare systems that have now started kicking children out of their practice if they do not follow their schedule, ACDC. You can no longer delay, you can't. The physician that I work hand in hand with, she is one of the physicians who is willing to see children regardless of their vaccine status, because now we're talking about equitable health care to all in Union County. She serves Mecklenburg as well. Some of these facilities are gaslighting parents. However misguided we may think they are, this doesn't allow us room to educate and talk with parents and move forward. I'm in a situation where I take care of addicts. We don't kick them out of our hospital for not being compliant. I take care of diabetics. We don't kick them out because they didn't follow their insulin regimen, but we are in a situation where we are kicking children out of a practice. We're missing opportunities to catch preventative interventions, tumors, cancer, things that pop up that we wouldn't catch if they weren't attending their regular scheduled checkups with physicians. This local pediatrician, she's been reaching out to legislators, all shareholders involved with the same topic to bring change. I think something else that we have to acknowledge is we can't expect parents as a whole to be on board with vaccines when we now have physicians that are not on board with what the CD schedule has had for decades. There was a big hearing 2 weeks ago in Congress up in DC. Many of your brightest physicians from across the country attended that congressional hearing talking about some of this. But if we don't catch it, if we're not allowing these young children to be seen in doctors' offices, we're going to run into added. We have, I understand what you said, refugees that come over with different cultures and have their own beliefs, but now that's going to collide with another demographic of communicable disease and explode. So,
you know, the hard part is not only are they losing their medical home, you lose the opportunity to have that conversation. You lose the opportunity to have, hopefully, a trusted and respected provider say, you know, if you want to space this out, let's space it out. If you want to do, we had one kid, we had to do one vaccine at a time, and they were here every couple of weeks, but they felt comfortable with that.
we have to meet the patients where they
Yeah, exactly. And I'm never going to tell a mom who, you know, hopefully all parents, they just want to do what's right by their kids. You know, I'm never going to tell you, no, you have to do this, or it can't be all or nothing.
Right, I agree.
Well, that's kind of where the problem lies,
Yeah,
or where
it
it
is.
started, was the all or nothing.
Right.
Okay?
I agree.
All or nothing with experimental things that really, I've seen people injured by.
The hard part is, you know, the best that we can do is provide education from reliable and trusted resources, and help make an educated decision.
Which is exactly what we should be doing.
Right.
But kicking people, and I'm not a pediatrician, but kicking people out of your office because they won't do just what you want them to do is the wrong thing to do.
Yeah.
They need to be educated, and maybe in time you educate them and learn that, you know, this vaccine might be good for you, but this one may not be, or whatnot. But you're not gonna have that opportunity to speak if you kick them out of the office. So that's what probably my hospice systems do.
Yeah.
They shouldn't be.
Right.
I have a question.
And for anybody who wants to do a delayed schedule, send them to the health department. We do that.
Good to know, because
Yes.
she's busted at the seams.
Yes. Yeah.
She's busted at the seams, like, and she's not going to turn children away. We have caught some of these pertussis cases that could have turned out to be one of your statistics up here. We caught it early. You know, they're using urgent cares kind of as doctors, and urgent cares don't test for all these things. So we were fortunate enough, she was fortunate enough, not we, she was fortunate enough to catch some of this early and prevent some of these statistics. So I feel like the only thing constant with science is change. When things are evolving, we have to evolve with it. If we are not going to be open-minded, the conversation stops, and we all lose as a community.
Can I ask what the purview of this board is, though? It seems like we're starting to get into some conversations that I want to know, what is my role right now? I mean, these are, I mean, I think they're all very interesting conversations to have, but in terms of the great work that you all are doing and the data that you're presenting and how this relates to the overall kind of public health and communicable disease, and also just to kind of keep us on topic, what is it that you need from us as the board with this?
So really, this is mostly for awareness, but
Just
also,
aware. Okay.
yeah, just know that
Yeah,
I think the board can always do some type of advocacy. And was I hearing you right, Brent? You're saying that some physicians just were were not taking patients? And so that's some type of, I don't know about the legal parts of that, but if they have the right just to say, I'm gonna take this one, I'm not gonna take this one?
That's what I had the question on. So your obligation with a public hospital is not the same for a hospital affiliated practice? Like, so if you're an atrium pediatric practice, you don't have to meet the same obligation of public health that the hospital does?
yeah, there's no public health,
For
Right, it's a
primary
different
care.
system.
it's, yeah, I mean, those systems
Right.
can, develop whatever guidelines and protocols that they want to put into play. And that doesn't come into, I mean, that's not a public health question. I mean, we don't have control over those facilities from that perspective.
An office can actually dismiss patients.
And
Yeah, they do.
Mr. Earl, thank you for bringing up the advocacy part of our role on this board, because I am fortunate enough again to see things directly, indirectly. I work in the ERs. I see things that some of you don't see. I hear from so many demographics, and this all plays a part in this report. And like I said, this pediatrician brought this to light 2 years ago, and here we are. That little bill is still sitting in our state senate, and now 2 years later, it's becoming an issue for Union County.
What's our role with
We have to
advocacy?
talk about it, and we have to be able to discuss and give options, opinions, advice.
What's our role as advocacy on this board? Like, I am a little confused as what, like, my role as a board member versus my role as a resident. 'Cause I think those are two very, and I'm not saying advocacy isn't great, but I just want to be clear about like what the boundaries are in terms of my role here. Can somebody who's been here longer than I have enlighten me?
Well, not as a board member, but I think that when I view advocacy, it's an educated awareness and understanding of the conditions that's affecting a county.
Sure.
And looking at all elements that come into play with that. And I think, one of the challenges we've seen, and it does go back to COVID, I mean, there's been a lot of divisiveness and a lot of, the vaccine hesitancy, but there's also been, the issue of trust is going to be something that's going to take a long time to build back. I mean, trust is something that, you can lose in a minute, and it takes decades and years to build it. And so, from the standpoint of what does that have in terms of an impact on our community's health, is, I think, a concern that as a public health professional, it's going to be a concern. And so as we talk about, as we see these trends, and it's not a matter of, okay, bad, right, or indifferent, it's there. And we have to continue to have that kind of open communication about it and look for ways to try to address it, and to the extent that we can. A lot of what we do is a lot driven by state and other agreement addenda protocols that we have to follow. But as a board, from my perspective, it's a matter of being aware of what those trends are and
Based on the data, the
based on the data that's there and what we're looking at.
Okay, so I have a question. You know, when I look at the slide you put up on vaccine hesitancy with the comments from different parents. So as a parent myself, then I think, okay, is there any, my question is there any safety and efficacy data on, because in the first year of life, a baby can get up to 28 vaccinations, is from what I read. I mean, you can verify that, right? So today, they get up to 28 shots in the first year of life. So is there any cumulative data, safety data, on the effect of 28 shots in a, I don't know what the average size of an infant is in the first year of life, but it seems like a lot of shots in the first year. So maybe that's where some of the hesitancy is coming from. And has the NIH, CDC, or the FDA released any independent studies validating the safety and efficacy of the cumulative, you know, effect of these 28 shots in the first year of life, or even all the shots? I think it's 78 now on the schedule from 0 to 18 years of age. Do we know? Because I know they collected, I know they have the data. They have a database.
They do.
And they have a database that tracks vaccinated and unvaccinated children.
Yeah. The hard part is that first year of life, that's when they're most vulnerable. That is when most of the conditions that they could come or be infected with, when they're most severe, the highest mortality. So, I mean, that's the big push to get those vaccines. And the problem, you know, a lot of, with the data, there's so many sources of information, some reputable, some vetted, some not. So just getting that reliable information, you could find bukus of studies.
Well, yeah, no, but I know that the NIH, CDC, and the FDA have never released an independent, validated, formal study. They've never allowed any independent scientists to look at the data in the vaccine safety data link database. So, unless I'm wrong, but you know, maybe if we had that data and they would release it, or they would issue a report, or maybe we can ask our state Department of Health if they have any information on that, then we could alleviate maybe some of the concerns and you know, of vaccine hesitancy. I mean, sometimes you got to dive into what the root concerns are, and then counteract that with data. But because our federal agencies aren't releasing the data, it makes you wonder. You know.
So we can't get the data from their.
Right, they have not, they refused to release the,
The raw data?
they have been it has been requested by FOIA, you know, FOIA requests data in this database, and it's not been released. Senator Ron Johnson from Wisconsin has done, you know, has done meetings on this. So there have been many officials, doctors, scientists that have spoken about it. So.
If y'all want my help at Wingate, I'm happy to take this back also to my colleagues, and because then, you know, that may be able to help us if that's something that you guys are looking for. That, you know, I'm happy to take it back to my colleagues across campus in the health sciences.
Any other questions?
Thank you.
Thank you so much. Thank you for your time.
Thank you, too. Very interesting. And was it Tracy's next?
Yes.
9 years interesting, but let me give it a shot. So I'm here this evening just to ask for your support as we seek to submit a grant application for National Environmental Health Association FDA grant funding which will support our continuance with training, education, and support for our program standards, FDA program standards. With this, it's a 3-year grant. It consists of several requirements. There are no matching county funds that are required. The requirements for the grant would be maintaining, so I'm just looking for the support of the board as we take this to the Board of County Commissioners for approval.
I'll do a motion to support and approve.
Can I get clarity? It's for all 3 steps, right? Today, you're wanting approval to approve and then to authorize.
Well, some of these steps can only be performed by the county manager. So this is the actual agenda item that would go then. So, but I'm here today for you all to support, which I believe you're a strong board and a well-educated board, and your support of an initiative like this can influence the Board of County Commissioners and move forward with their approval of this item.
Yes, if I like how it says no county funds, and
No
one
county.
question, if I was a board member, I'd probably say, how's the sustainability after the grant? But with no county funds and.
I would say the funds that we've received previously have enabled us to obtain these standards that we've already gotten. It is evidenced every day in our inspections and our training of new staff and the strengthening and the confidence that we use when we're conducting these inspections in the community. Yes, ma'am.
So the grant is for 3 years of training? Is that what it would be used for?
Well, the
Or
funding is
funding?
spread out over 3 years, yes.
And that'll go towards training, correct?
Primarily training, yes.
Okay.
Yes.
And then after 3 years, what happens?
The money goes away, but we'll have used that money to satisfy these requirements. And then, at that point, hopefully, my goal was to have all 9 standards, all 9 FDA program standards, and then it will be us to maintain those standards long-term.
Is there ongoing training after 3 years?
There is required ongoing training to maintain standards,
Right.
yes.
Okay. And how will that be funded?
Well, we have, in our regular budget, we have training budgeted for. Sometimes that training includes travel. This just enhances our ability to get some of that heavier training on the front end. That may be offered in another state or is just much more cumbersome on the front end. Typically, the renewal training and the ongoing training isn't quite as expensive. Also, the other thing I would mention is we have so many new staff. So a lot of these folks are taking the training for the first time, and so this gives us the opportunity to send more folks to the training rather than just one year, one another year, that kind of thing.
So no county funds, so where's the $60,000 coming from?
It comes from the FDA,
Oh, the federal? Sure, good.
and it's in partnership with the National Environmental Health Association.
Okay.
So we know that the FDA does not have enough inspectors or funding to do everything they need to do in the United States of America. They depend on local folks, state folks to assist, because this is where the consumption is. And so we are in regulatory and retail program areas to do the boots on the ground inspections. We're not just, doing an inspection of a box on a port in San Antonio, or not San Antonio, Houston, or Los Angeles, or, Virginia. It's an integrated national, state, local, and in many ways international food system. And it takes all of us working together. So $60,000 to Union County, doesn't sound like a lot of money, but there's a lot of work that can be done through education and outreach and just individually day-to-day operations.
Your long-term goal is 9, to do
That
all
is
9.
my
This will
goal.
take you from 5 to 6
That's right.
for that 3 years.
Any other questions?
Do we have a motion? I motion that we approve and support.
Thank you, I appreciate it.
All agree? Say aye.
Aye.
Opposed, say no. Okay, thank you, Tracy. Are there any more division reports?
I'll go. Just a few things. I hope I gave everyone our State of the County Health Report for 2023. I actually presented this, oh gosh, back earlier this year, maybe April or May of this year, but this is the actual copy of the material. And I will point out, since the question came up, that on page, I think it's 3 and 4, you can see some charts on morbidity and mortality changes since the last community health assessment. So there's some trending on here on some of those questions that you had before. Some of the way that the data is pulled a little differently, but you can see what the per 100,000 in the population, but you can see where we're trending, where we compare to North Carolina. And we do this every year except the year we do our community health assessment, which is in 2025, which is a huge thing that we have to do for accreditation, and do that along with our Healthy Union Advisory Coalition. But we do pull a lot of data, which brings me to the next thing I was going to say. We are working on a regional community health assessment with 10 other counties and 6 of the hospital systems, including Novant and Atrium and a few others around the state. And we're really excited about that. The western part of the state does a regional one, and I believe on the East Coast as well. So finally, the kind of the center of the state, we're all doing one together, which is going to be really nice. And there's some funding to pull some of the secondary data that you kind of see in here. And if you go online, you could read our community health assessment for 2022. It's really long. It's very comprehensive, but we look at all areas of health. We'll have, they are we're going to be working with a couple of different organizations, again, pulling our secondary data, which is the statistical information, and then primary data, which are surveys, focus groups, interviews with folks. So we're really excited that we're going to have those resources to help us, and each of the counties is going to get that assistance too. So it'll be great. But me and Anna are on the committee. I know Dennis has been attending, and Janet when she's able to as well. So that's something we're participating in. And then the last thing I was going to mention is Heather Horn, who is my program manager over a lot of our initiatives out in the community. So our health education, health promotions, our parenting program, our volunteer program. She has resigned because she got a position as a health director for Richmond County. And so we're really excited for her, but it's a huge loss for us. So her last day is the end of this month, and we are recruiting for that position, looking really for someone preferably with, experience with a CHES, which is, community health educator. Someone with a master's degree is really preferable too, at that education level. But that position is super important. It's also our engagement in the community. So, and she's done a lot of great work over the last 5 years that she's been here. So, just wanted to announce that.
Stephanie, you want to say anything about Christmas Bureau?
Of course. We have kicked off our Christmas Bureau, so that's something that we do annually. In other counties, sometimes nonprofits are over the effort, but we are responsible here in my division. That's part of what we do. We kicked off taking applications last Monday. We actually have a separate Spanish phone line, so we take all these applications over the phone. And I know we've already had a significant number of applicants. I don't know what that number is. I know, I talked to one of our workers and she said we had 80 Spanish-speaking folks call up, which is a lot of the population we serve here. And I don't know how many non-Spanish speaking. I'm sure probably twice as many. And then we also provide gifts for our seniors and also for our foster children all over the state, wherever they're placed, if they're in our custody. And we serve well over 800, 900 families every year through that. And we would love donations, and you can go online and look at where you can donate. Jen's like, oh, yeah, donations.
And it tells like what kind of donations you're wanting.
Exactly. And there'll be opportunities later on to volunteer as well. And we're really excited. We've always loved when people volunteer. And we are doing this, last year we had to do a lot of this in our building here. Because the location we had wasn't big enough to distribute gifts, but we now have a location that is big enough to distribute the gifts out of and collect and do all the volunteering. So we're excited about that.
Is there an age restriction on your volunteers?
Usually we ask if children are under 18 or 16, 18 to be with parents.
But as long as they're with
Mm-hmm. Yeah, absolutely. A lot of the kids got their community service hours helping out. It's a lot of fun.
Hi, good evening. Michelle Marcano, Veteran Services. We are having our annual Veterans Day ceremony on Saturday, November 9th at 10:45. We do the opening ceremony for the Charlotte Monroe Executive Airport Air Show. That's a mouthful. Our keynote speaker this year is a surviving spouse, which is a little bit of a twist. I really try to keep our speakers as Union County residents. Sure, I could bring people in from Washington if the commissioners would approve that budget. But locally, you know, these are our people. These are our Union County residents. And Mrs. Seymour is the surviving spouse of a Purple Heart Vietnam veteran who she cared for until his passing. And she's also an author. So I thought that would be a great pick. And I hope that you all can come and see us. Thank you.
I have a couple of other things as a follow-up. Thank you guys so much for the report today. You asked about the refugee health assessments, so just a quick little bit of information about that for the assessments that we've done here. So from 2016 until 2019, the most that we had done in a year was 37. In 2022, we did 201, so about an average of a little less than 17 per month. In 23, 215 over the year, so a little more than 17 per month. And this year to date, as through August, we had done 158, so we're averaging 19.75 per month. So just a little bit of information from a volume perspective in association with that. I also just want to say that thank you to a lot of our staff who have helped support and are willing to help support the efforts to support our friends and family and fellow neighbors in Western North Carolina in service in response to Hurricane Helene and the devastation that caused. And so I'm very proud of our team members from Human Services and from Public Works and from other teams who have been able to go and participate. And just obviously we need to keep those families and individuals in our prayers because there's a lot of devastation. And lastly, I want to thank Meg again for your service, and we appreciate you very much, and we appreciate you very much. So we're going to miss you. All right, I think that's all. Oh, I'm sorry. Commissioner Williams.
No announcements, Mr. Chairman.
Well, I was just getting ready to ask. Okay, if there's no more division reports, any parting comments from staff or board members? Well, in that case, I'm going to ask for a motion to adjourn. Got a motion? Ready? A second? Okay. So this meeting is adjourned. Thank you so much.